Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, LIMR Education and ESO, we are able to make science more accessible and understandable.
All right, welcome everyone to the September already 2023 edition of the Pre-Hospital Care Research Forum Journal Club. Special thank you once again to our sponsors, LIMR Education and ESO, for making it possible for us to be here together today. I'm Dr. Emily Crow, and today I am joined by Dr. Tony Fernandez and Michael Caduce. And we will be reviewing a paper called The Impact of Pre-Hospital Pain Management on Emergency Department Management of Injured Children, which has been published in Pre-Hospital Emergency Care. And as always, this discussion is paired with a column in EMS World called Journal Watch, written by our very own Dr. Tony Fernandez and Michael Caduce. So I encourage all of you to go check out this edition as well as past editions on the EMS World website under the category of education and training. Thank you all who are here with us live today. As we begin, let me remind you that you can use the Q&A feature or the chat feature on your screen to ask questions or add in comments, and we'll bring those into the discussion with us as we go. Should be a good one today. And with that, I think all of our logistics are in order. Let's go ahead and talk about the paper at hand. So the objective of today's paper was to look at the impact of pre-hospital pain interventions on things that happen in the emergency department. And those things specifically being emergency department pain scores, the timing and dosing of emergency department analgesia, and whether or not there was any reduction in pain. So first things first, why does this topic matter? And Mike, I'll turn it over to you. Talk a little bit about what do we already know about analgesia in the pre-hospital setting, particularly around analgesia for children.
Good morning. Thanks for Emily. What we do know is that there have been other studies that have looked at similar criteria and similar patient populations, so those between about 1 month and 17 years of age. And we know that we're not treating pain the way we should be. We know that we're underdosing pain management if we're giving pain management or analgesia at all for our pediatric patients. That's been well documented in the literature. It's been well supported, I think, as EMS providers. We probably all know that as well. Sometimes our children patients scare us or concern us, especially when we're giving an opioid medication. Wouldn't be the first time that I've heard an EMS provider say they were hesitant to give a medication. It involved some math, and usually that's a hindrance. Anytime we have barriers to success, we know that that's going to reduce the actual rate of application. So barriers to success in delivering pain medication for children include doing the math, figuring out what your dosing structure is, and then giving it to the patient. So I think all those things apply here. When we start looking at this study, I think we'll see if we find results that are similar to the results this study found and what we've seen historically.
That's great. And it is important background. Historically, EMS has not given a ton of analgesia, particularly when we're talking about pharmacologic analgesia in adults or in children. And with children, there's definitely that special set of barriers that you mentioned. I think the topic of this study is really interesting because it's looking at that continuum of care. How does what we do in the pre-hospital setting potentially affect what's going to happen at the emergency department? And it takes on that myth or that notion of, well, I'm just 5 minutes away from the emergency department, so should I delay transport to administer analgesia here, or do we go ahead and just go to the emergency department? And I always make the joke of, well, it's not like the fentanyl gods magically descend upon you at the ED doors. We might actually be prolonging pain, not to mention the pain that happens during a bumpy transport. So this is a really important topic, and it was conducted within a well-established research network. So some of you may have already heard of PCARN, but for those who haven't, Tony, perhaps you can tell us a little bit about what is PCARN, which is where this study took place.
Yeah, so PCARN, that stands for the Pediatric Emergency Care Applied Research Network, right? And this is really interesting. This is the first federally funded multi-institutional network for research in pediatric emergency medicine in the United States. So this is kind of a big deal. And when they use, PCARN has done a whole host of very meaningful research, but the goal of the network it's to conduct rigorous multi-institutional research into the prevention and management of acute illness and injuries in children and youth across the continuum of emergency medicine healthcare in the United States. So the really, really cool initiative, and they've done a lot of good work, as we'll see today.
Absolutely. And PCARN is broken into several different nodes. And so this study in particular took place within 11 PCARN emergency departments. And so this is probably a good time for us to go ahead and transition into some of the methods so that we leave lots of time for results. So Tony, I'll let you go ahead and take the lead on this, but let's talk about when and where the study took place specifically within PCARN.
Yeah, so this took place from July 2019 to April 2020, and this was a planned secondary analysis of a prospective multi-center cohort study. So that's a mouthful, right? And for some of our newer researchers who are listening to us and watching us today, essentially what this says is this was a study that they took. This was a prospective study, but this wasn't their initial analysis. What we're going to review today. This was something that they had planned, but this was gonna be after the original analysis that they performed on this study population. The children were eligible for inclusion if they were 1 month old to 17 years old, and they had to have an injury-related chief complaint, and they had to be transported directly to one of the participating sites by EMS. And they had some interesting exclusion criteria. All of these, I think, were wise choices. Traumatic cardiac arrest, anyone with known hypersensitivity to opioids, and patients who were pregnant were all excluded from this study. So as we move on, they had some interesting things that they and as you go through and you build a career in research, you'll understand how important your research coordinators are. And the research coordinators played a really big role in this study. What they did was they enrolled patients, and they were available to enroll patients 16 hours a day, 7 days a week. So that's not a small task. And they screened for eligibility using the electronic patient tracking board that was in the emergency department, pre-arrival notifications, or communications directly with ED nurses or clinicians. What they did was they wanted to look at patients who had opioids, any type of pre-hospital analgesia administered, including opioids or non-pharmacological pain management. These non-pharmacological measures, they included things like splinting, cold packs, or simple distraction for a child, and they were self-reported by the EMS clinician. So essentially, the research coordinators were looking for ambulances to come in who cared for patients who may have been injured, and they asked the EMS provider, did you provide any pain management for this patient? If the EMS provider was unavailable to answer these questions, they did go back to the reports to see if pain management was delivered. But one thing that's important, and this will be important as we go through our results, is they did not specifically collect which opioids were or what type of non-pharmacological pain management was administered. It was a yes, no, and we don't have specifics into which works better and the like. Or at least the research coordinators didn't collect that information. So again, research coordinators are worth their weight in gold. So they abstracted and entered data into a medical research database, and they allowed for a week so they can capture all of the hospital data, and then they linked data from the EMS and the emergency department based on patient name, date of birth, chief complaint, the encounter date, and the encounter time. One thing that I thought was really interesting about this study, and this is not something that you see often, is they actually actually had a data quality kind of session with the investigators and the research coordinators before the data were analyzed to ensure accuracy. So the research coordinators would be able to clarify questions regarding the data abstraction and just kind of make sure the investigators had a full understanding of the data that they were about to dive into. So that is that all of that, I can't emphasize enough how much work goes into all of that. And it certainly paid dividends for this study.
Absolutely. And it's unusual to have this kind of prospective data collection. So that's a big strength of this study that we should highlight, is that by having the research coordinators and enrolling patients as they came in, this was a prospective study where they were actually capturing that data live and then entering it into a tool called REDCap, which is a data collection tool. And one of the other things that sets the study apart is that they actually obtained consent from the parents. So typically we're using retrospective EMS records and trying to pair those up with hospital records. But in this case, this was prospective research where consent was actually obtained.
I think one of the other very interesting parts of the methods is they actually broke down what the non-pharmacological pain management interventions were. As a primary EMT educator, where the EMTs are not giving an analgesia, they're giving some sort of other method. I really appreciated that they took and then we'll get to this when we get to the discussion because they broke it all down. They looked at whether splinting was applied, whether there was cold therapy applied, and even distraction. So giving the child something, a toy to play with or a video to watch or something like that. So I really appreciated that the authors took the time to say, we recognize not everybody that's bringing in a pediatric patient with pain can give an analgesia, but we want to see, did they do something to try and prevent the patient from experiencing that pain.
Yeah, all great points. I mean, there was a lot of really important interventions and methods that they took in the study to make the results kind of really clear and understandable and really precise. So I think as we go through, we'll talk about some more of these things. So they grouped their pain scores, they grouped their patients, excuse me, by their pain severity scores. And they, a priori, so before the study was done, they had three basically pain groups that folks went into. So either mild, which was a pain score of 0 to 3, moderate, which was a pain score of 4 to 6, and then severe was 7 to 10. And then they wanted to, again, compare analgesic medication administration in the emergency department. They converted all, just for ease of analysis, all analgesic medication administrations were converted to morphine equivalents. And they had two outcomes that they evaluated. Their primary outcome. So the first question that they wanted to answer was they wanted to compare the difference in pre-hospital and ED pain scores between patients who received opioid analgesia or non-pharmacologic pain management and those who did not. So anyone who had some kind of pain management and anyone who didn't. For their secondary analysis, which was interesting, they included the time of first administration for the ED opioid analysis, the total morphine equivalent administered in the ED, and they compared that between groups, and they stratified it by those who received only non-pharmacologic EMS interventions and those who received some kind of either one or both non-pharmacologic and pharmacologic interventions in the pre-hospital setting. So a lot of different ways to slice and dice the data that we'll be able to go through in the results section. As we move through, their analysis was definitely appropriate for the data that they had. They ran through and they presented their descriptive statistics, and they ran a logistic regression model to identify the patients and the provider characteristics that were significantly associated with ED opioids. And some of the predictors they included in this model were the EMS opioids, non-pharmacologic EMS interventions. They looked at pain severity, the presence of long bone fractures. They looked at the certification level of the provider's experience, the ED pain score, the patient age, patient sex, race, ethnicity, and insurance status. So this was really interesting that they were able to build a model and look at all those different predictors as well.
I agree. And with the pain severity variable that you mentioned, I think it's worth calling out. Well, they included children as young as 1 month. And when we're talking about those pain scales, we typically just think of the 0 to 10, or maybe even the faces that a child could point to. But, what about in the younger children who are nonverbal? What kinds of assessment instruments can we use in the pre-hospital setting? And this is probably an area that is going to warrant further investigation. There are observational pain scales, and this is very helpful for especially those younger age groups. So something like the CHIOPS or the FLAC. So it's not enough just to say, well, the child was too young, so I couldn't do a pain score, so I can't do anything to relieve pain. And that's something that we should be thinking about too, as early as our initial education programs.
That's a great point.
I couldn't agree more, especially on the education side. As many of these barriers to successful pain medication we can eliminate. The Wong-Baker is another one, the Smiley scale. Anything we can do to indicate to our providers. I think it's interesting. We sort of keep talking about treating pain, whether it's non-pharmacological or non-pharmacological. There's actually, and I think it's 2021, but somebody can tell me if I'm wrong. There's a publication on what the pre-hospital pain management guidance is specific to children, and that it really is the standard of care to be administering some sort of pain management. As we get into the results, we can see if that's the case, but it really is published and well documented that pain management, including analgesics, is safe and should be considered the standard of care in children with pain.
Absolutely. And that's right. I think that's an important document you referenced is the 2021 evidence-based guideline on pre-hospital pain management, which does include a section on children. And in fact, one of the only strong recommendations that was able to be made because of a lack of evidence in most cases. But in this case, there is really strong evidence towards having intranasal options available for children. Specifically in this guidance, it says intranasal fentanyl. But we can think about how important that is, not just our assessment toolbox, but our pain treatment toolbox, expanding those to have different options available, because an injured child, the last thing that they probably need is a needle, which most of us are afraid of, myself included. Fine with putting them in people, don't like having them put in me. But these are things that we should be considering as the evidence is developing. And so I'm very excited to see this study as a baseline. And, I want to check back in a few years, and hopefully we've made a lot of progress in this space. So I'll ask panelists any further questions in the methods, or anybody in the audience, any questions in the methods before we go into the meat of this study, which is the results. All right. So let's first talk about who was in this study. How many patients did we have? They started by looking at all patients who were injured in the pre-hospital setting, where EMS transported to an emergency department were potentially eligible. So there were 547 patients who were eligible to be included. However, either patient or patient's caregiver refused to be in the study. They did not sign the consent, or eligible was missed. Remember, those research assistants were not working 24 hours a day, so it is possible that some were missed. That left 501 who were captured for inclusion, and then due to incomplete pre-hospital documentation, 27 were excluded, leaving 474, which is a large sample size in a pediatric study. And this is another strength of having a research network like PCARN, where we're able to bring together data from different emergency departments. Whereas if we had limited this study to just one emergency department, it might have taken a really long time to get together this many patients for us to study. So 474 is a great number to look at. And then they further break that out into the different intervention categories, which includes non-pharmacologic intervention only, like Michael mentioned. Those are important things like splinting, ice, distraction, positioning, opioid analgesia only, or a combination of non-pharmacologic and opioid analgesia, and then a group who didn't have any documentation or any reporting of pain interventions. All right, next up is going to be Table 1. And so this is our traditional Table 1 that includes all of the characteristics of those patients who were included. In this case, the characteristics are split out by the different treatment groups, those 4 treatment groups that we mentioned before. And the authors did find some important differences here that are worth commenting on. So for those who received either opioid analgesics or the opioid and non-pharmacologic analgesia, so those are the first 2 columns in Table 1 for those who might be following along. Some things that stuck out to me were that these patients were more likely to have severe pain. So to give an example, the mean pain score, and that's that 0 to 10 pain score, was an 8.7 in the groups who did receive pharmacologic pain management, versus a 6 in the group that had non-pharmacologic only, versus a 5 in the group that had no intervention. But perhaps even before talking about that, it's worth mentioning that pain was only assessed in 77% of patients. So there is a group with missing pain assessment that's important for us to remember. But going forward, this is just looking at that group that had pain assessment and looking at their pain score for this particular variable.
I find that really interesting, Remley, this sort of mild, moderate, or severe pain. I think to myself, if I had a pain scale of 5 out of 10, I would still want something for it. I would be pretty vocal about wanting some pain management for it. I think back to even children, if I've got a child, certainly their pain's at 8, 9, or 10, I'm thinking that's a pretty high level and I want to be treating that. But as an EMS provider, even hearing pain management or pain scale of 5 or, the middle of the scale, I'm a little bit miffed because I feel like if it was me or if it was a child, well, I don't have children. If I did, I'd feel like that they deserve some pain management, something, even if it's not, a narcotic.
And that's a really key point is, this is not referring to just, pharmacologic management. This is referring to any, and overall, only 55% of patients received any form of pain management, pharmacologic or non-pharmacologic. And so that's a huge gap. And then when we're talking about children, one of the potential effects of this is that this could influence their relationship with healthcare. So having that traumatic memory of pain and not having that pain be treated can set the stage for future interactions with healthcare. So this is and it also affects the healing process. There's a lot of research on why it's important to treat pain, and also that knowing that treating pain doesn't just mean going straight to opioids, that there are a lot of different ways to treat pain. Even, if we want to say, I'm on a basic life support unit, I can't possibly do anything. No, there are a lot of options there as well. So I think that's one of the key things that stuck out to me is that probably clinicians are doing a good job at identifying patients who are in severe pain, but there seems to be this hesitancy to treat anything that's below severe pain. And then we can imagine in the group that did not have a pain assessment recorded, likelihood of getting treated was probably even lower. A couple of other things. Go ahead, Tony.
Oh, I just wanted to mention some things that, we talk a lot about things that are statistically significant and how important it is to have statistical significance, but a lot of that is driven by how big your sample size is. And we have some smaller sample sizes, even though we were able to bring in a lot of patients because they were from 11 different emergency departments. But there are some trends here that if the population was a little bit bigger, might gain statistical significance and are worth paying attention to. Some things are maybe confirmatory, right? When we talk about patient age, we can see kind of a trend that the younger patients aren't getting any pain management, and that's something that is kind of confirmatory that we probably all believed was true, but we can see it right in front of our face in the data here. And there's certainly some differences, even though they're not statistically significant, patient race here and who's getting analgesic and non-pharmacologic measures and the like. And then there is a statistically significant difference when we look at patient ethnicity. So there's some disparities there that I think are, even though statistical significance may not be the driver for us to pay attention to, they're worth putting our eye on.
Yes, and these findings have been replicated in adult studies for a long time. So I think that these inequities are worth paying attention to. And I know that I instantly become very unpopular anytime I bring these up, but they're worth mentioning because I don't think that the vast majority of providers wakes up trying to treat patients differently. And in fact, I get a lot of hate mail or comments on EMS1 articles about, I treat everybody the same, I don't see color. There's some problems with that because implicit bias is a thing and our brain takes shortcuts. It's how it keeps us alive. And so when we see data time and time again showing the same trend, it tells us that it's probably not an individual person problem that we have, but rather a system system problem that needs addressed. And so pain management is a really interesting topic to study because there is a lot of discretion in the protocol. It allows for clinicians to make that judgment on, should I administer an analgesic? And if so, which type of analgesic and what dose should I give? Or, nothing bad is going to happen to me per se if I don't do this, and it's extra work for me, and I'm 5 minutes from the emergency department, and it's 3 a.m. So you can see how all of these things add up. And then in support of that, you can also see one of the lines down here in table 1 talks about long bone fractures. And so patients with long bone fractures were substantially more likely to get pain management. And that goes back to that kind of value-based judgment. This is an objective injury. We can usually see if there's a fracture, or perhaps there's some angulation or an open fracture even. And so these patients were far more likely than patients who didn't have a long bone fracture to receive pain management. Things for us to also consider in our protocols and in how we are approaching pain management for injuries.
I think that's so important to recognize that long bone fracture point, Remley. We have this pain management, whether we administer it, is up to our perceived level of the patient's pain. Often, I can see a long bone fracture. I can assess it. I can palpate it. I don't know that we're auscultating that, but abdominal pain, chest pain are things I can't see really the difference between a sign and a symptom there, which is telling me that a lot of pain administration or pain management is perception based rather than what my patient is telling me, what I'm hearing from my patient. It takes me back to the classroom and thinking we really need to make sure that our initial education providers and our continuing education providers understand that pain is a metric, and whether or not my patient gives me a number that I feel like is substantial pain or not, my patient's telling me they're in pain, I have an obligation to take that seriously and develop a treatment plan accordingly.
And pain management is such an interesting intervention in that space because there's not really any other interventions where it's, do you deserve this treatment or not? Whereas in pain management, it's like, well, you said it was a 10, but you're on your phone, so it can't possibly be a 10. But distraction is a powerful tool. There may be reasons why we're on our phone. And so this value-based, you have to prove it to me in order to be worthy of getting pain management, is unique to analgesia. We don't see this for something like a 12 lead, right? You give them a 12 lead, okay, fine. The protocols are less discretionary there. So this is an important space for us, or in any protocol where there's discretion, for us to pay attention for health inequities as well. So I love that we were able to pull out that point from this table 1. All right, I'm checking the comments for chats. All right. And I think with that, we can go ahead and move into the next couple of figures and graphics, because there's a lot of great information in this study, and it really does build on the evidence base around pre-hospital analgesia. So here in figure 2, we have pre-hospital opioid administration by the pain severity category. So this goes back to that value judgment on, if it's not severe pain, should I be giving an opioid medication or not? So here we see that even of patients with severe pain, only 36%, so that's about 1 in 3 patients with severe pain received any opioid management. Compare that to moderate pain, that drops down to 8%, and then mild pain drops down to 1%. So, I don't like my odds of 1 in 3 getting pain management if I'm having severe pain. So this is definitely an area where we can focus on.
And it's something, we can be patient advocates here, right? This severe pain, this is something that, and we'll see, there's an argument, right? What we do in EMS, when and where does it matter, right? As we go through this study, we'll see that it matters in a whole host of different ways, but certainly in treating pain, that's something we can do, and we can do on the spot, particularly for those with severe and moderate pain. I think that this is an eye-opening graph right here.
This is an eye-opening graph. And then there's, a lot of myths and things that have also been disproven with research around, this prove it to me concept of, you say it's a 10, but it's not really a 10, or everybody is just drug seeking. Their heart rate's not elevated, therefore they can't possibly be in pain. A lot of these ideas have been disproven, and so using vital signs as an indicator of, prove it to me, do you actually have pain, is not the best way to go about this. So certainly, are there patients who are seeking medications? Absolutely. Is that the vast majority? The data would suggest that's not true. And so this is something for us to check ourselves and our own cynicism and burnout on when we're saying, do we really think that 64% of patients with severe pain weren't actually in severe pain? Or do we have a treatment gap that we can probably improve?
I think this study is so important at breaking down some of these myths, right? Most children are not coming to the emergency department with drug seeking, opportunity, or not doing that. Maybe that's the case in some of our adult patient populations, but I know it's not as high as what I hear people telling me why they didn't give pain management. Similarly, our kids are not typically lying to us about their signs and symptoms, or we certainly don't assume that to be the case. So I think that really breaks that myth of, well, I give pain medication to everyone except those that I'm worried about. I also hear the myth that, addiction is a problem, and we know that's a problem to narcotics. The evidence in addiction studies do not indicate that people become addicted to narcotics from routine administration in the pre-hospital setting from one transport. It's long-term usage over several weeks to months, usually after they leave the hospital, that addiction develops. So I think, again, as we break down the myths of why we do or do not treat pain, looking at our pediatric patient population is incredibly important to show that there is a disparity here.
Absolutely. And just expanding our toolkit. So if we're worried about opioids, there are a lot of non-opioid options available as well. And so revisiting the evidence and revisiting our protocols becomes important. For example, IV Tylenol, which Offermev is the name brand of that, has lost its patent. And so that medication was historically pretty expensive, but as of about a year and a half ago, it lost a patent. So generics should be coming out, and the cost of that may change. So we should also consider changing our practices with regards to that. Ketamine is another option that has been used in children at analgesic doses for a long time, also available IN, which is an important non-IV route. So I agree. I think that looking at this should be our wake-up call to start thinking about the why behind it. Now, this study did not attack the why behind it. Its goal was simply to describe current practice and how this influences treatments in the emergency department. And so we could move into table 2, which is really the crux of the study. That is the drum roll, please, outcome table. And so I'm going to go ahead and move us over there. And here in table 2, we have the columns for the groups of treatment. So opioid plus non-pharmacologic only, and no pain management. And we look at things like their first emergency department pain score. Now, hold our thoughts on this one. The summary is that the initial ED pain score was higher in the groups who received analgesia. So that must mean that the analgesia was no good, right? Wrong. We'll see on the next graph how their pain score started and then how they arrived at the emergency department. Next is the change between the EMS pre-hospital pain score and the emergency department pain score. So here is an important finding. The difference in the EMS to the ED pain score was much larger and in the form of a reduction for patients who were in those analgesia groups. So we see that it was on average a 2-point reduction in pain score between EMS and ED for those who received opioids. Now, in those who received non-pharmacologic only, the difference was 0.8 on that 10-point pain score. And then for those who received no documented interventions, the reduction was a 0.3. Now, typically in research studies, we consider a pain reduction of at least 2 points to be clinically meaningful. So those who received the pharmacologic interventions had a clinically meaningful pain reduction. And then we get into some really important and interesting findings. So emergency department opioid analgesia. We might think, well, if I give them pain medication in the pre-hospital setting, well, they're going to be far less likely to get it in the emergency department setting. But that's the exact opposite of what these authors found. So those patients who received opioids pre-hospitally were far more likely to continue to receive opioids in the emergency department. So there's this concept known as diagnostic momentum, and EMS has a huge ability to influence the diagnostic momentum. By treating pain early, it's far more likely that the patients are going to continue to receive pain management. And then same is true for dosing. So patients who received pre-hospital opioids were more likely to have a higher dose of pain medication in the hospital setting, and especially within the first 60 minutes of care. So this helps us bust some of those myths on, oh, well, if I just don't give pain management, they'll get it when we get to the ED anyway, or I'm going to somehow, erase the pain pathway or something important. The evidence here suggests that when we treat pain pre-hospitally, the patient is going to be better off and have more likelihood of having their pain treated in the hospital as well.
I think that's a key point. And just looking at figure 3, it made me, I wrote this down, the hospital will treat your pain, in quotes. Like, this is what we tell patients. Well, we're close enough to the hospital that the hospital will treat your pain. Clearly, that's not the case, actually. If we treat your pain in the pre-hospital setting, you're much more likely to continue that dosing once you get to the hospital. So this myth that, well, the hospital will just take care of that really isn't true. In fact, us delaying pain management similarly delays pain management in the hospital. So I think that's an important fact to consider as we start talking about what's the takeaway from the study, what should we be doing, is you actually are a big part of the continuum of care here. By initiating the pain management and treating your pediatric patient's pain, you actually may make them feel better, both in the ambulance and in the hospital. I go back to a couple other myths that, like, well, does it really matter? Does giving steroids for asthma in the pre-hospital setting really impact your patient? Well, yeah, actually it can delay the amount of the number of days that you're spending in the hospital. So there is a real term consequence there. We just don't always see it. I'm not going to see it in the first 5 minutes of care. That doesn't necessarily mean you shouldn't do it. In fact, usually that's not a reason not to do it. So treating patients' pain in the pre-hospital setting has a big impact on their ED care that I think most EMS providers don't realize.
Absolutely. And we know from prior work too, this notion of I'm just 5 minutes from the hospital actually delays the care, not just the 5-minute transport time, but the average time to provision of an analgesic in those cases was over 30 minutes. So by and large, we're prolonging pain by not administering in the pre-hospital setting, and we're increasing the risk of they might not get that pain treatment at all. That might go undetected, particularly when things are very busy in emergency departments. We have long offload times and other systems level factors here that could result in a much longer experience of pain. And then here in figure 3, I really like this graph because it shows box plots for those who received no pre-hospital opioids and those who did receive pre-hospital opioids. So the pain scores for those who did receive pre-hospital opioids, which is this box on the right, the lighter colored box, we see that their initial pre-hospital pain scores were substantially higher, which fits with our expectation. But then when we get to the initial emergency department pain severity score, we can see that lighter color box, the ones who received pre-hospital analgesia, shifted down drastically. So while it was still higher than those who didn't receive analgesia, the change in pain was substantial between having the pre-hospital opioid analgesia and not. Now I'll bring us over to one more graphic. I think this one is the Kaplan-Meier that Tony mentioned from the methods. This is looking at time to first emergency department opioids based on what happened in the pre-hospital setting. And so here we can see that the curve that is on top is the group that received pre-hospital opioids. And what this means is that a larger proportion of these patients received pain management in the emergency department and received it earlier compared to those other groups.
Yeah, and I think that's a good point. It's not just that they received it, it's that they received it quicker. Just because someone gave it to them pre-hospitally, we not only does it matter, we can impact care, we can impact care throughout the continuum of care. I think this is just a really great graph.
Absolutely. This is a great visual to see the impact, in that early course of care where there's the most time to make a big difference. And then I will take us over to table 3, which is the results of the multivariable logistic regression models. So this is looking at whether or not emergency department opioids were given as the outcome. And so when EMS opioids were given compared to not given, there was a 4-fold increase in odds of getting emergency department opioids. And Tony and Michael will tell you that, as an epidemiologist, get really excited if I see an odds ratio of 1.2, but to see an odds ratio of 4 tells us that this is a really large effect that we should be paying attention to. And then some of the other factors. Oh, no, go ahead, Michael.
I was just going to add in, I think sometimes we are a little bit maybe misconceived when we say, well, the hospital doesn't care what I'm doing. The hospital, they don't listen to my report. They're not, it doesn't matter what I say. this study debunks this completely in pediatric patients. In fact, there's a huge impact on what you say when you're saying we perceived pain, we treated the pain accordingly. The hospital is clearly taking some rationale from that when it comes to treating patients' pain. And certainly there's an assessment involved, and they're making some realizations themselves and some perceptions themselves, but a fourfold increase, that tells me that they're listening to what we're having to say, and they're basing their treatment on what our treatment was initially in the pre-hospital setting.
Absolutely. And then in addition to the EMS treatment, a couple of the other variables that they highlight for us here are that point around long bone fractures. It doesn't just hold true in the, descriptive analysis. Here, long bone fracture was associated with a 9-fold increase in odds of ED analgesia. Again, these being those objective injuries that are easier to detect, and with our value judgment of, well, of course a broken bone hurts, versus, well, they twisted their ankle. That's probably some value judgment on whether or not that's somehow worthy of pain management. And then with increasing pain scores, so they looked at the initial pain score in the EMS setting as well as in the emergency department setting. And this shouldn't surprise us that increase in pain score was associated with increase in odds of emergency department opioids. But it is something for us to keep in mind when we're modeling and when we're studying these things, to actually look at that pain assessment. And this, again, doesn't include that 23% of patients who didn't have a pain score. So that's something for us to consider too, is conducting a good assessment is where this really all starts. And so if we're able to conduct and document a good assessment, we can advocate for our patients and make it a lot more likely that they'll receive treatment for their pain. All right, and then last table is table 4. And this is just looking at the medication doses that were administered. So for those who received non-pharmacologic and pharmacologic intervention here, or what we have is for morphine equivalents, and I don't know that we explained this well, but this is something actually worth looking at because it's a very creative way of looking at dosing. When we want to compare different medications, so let's say that fentanyl and Dilaudid were used, it wouldn't be a fair comparison just to compare the actual dose of those medications. And so something that's commonly performed is to translate these into morphine equivalents. And that lets us compare apples to apples across medication classes, which is what the authors did here. And so what they're looking at is whether or not the ED morphine equivalents differed for patients based on their pre-hospital pain management, whether they received pharmacologic interventions or not. And overall, we see that those with non-pharmacologic interventions were more likely also to have higher emergency department morphine equivalents, suggesting that any treatment, even if you can't provide a pharmacologic intervention in the EMS setting, is likely to be associated with the emergency department hearing that report and continuing the care and then initiating that pharmacologic treatment.
I think that's really important. And I think recognizing, so this table looks just at the percentage of patients treated by our EMTs, or those are not giving some sort of narcotic pain management. There's a huge deal here. So if you gave ice, if you splinted, if you distracted the patient, again, the hospital is seeing that, they're hearing that, their treatment is changed based on what we're doing in the pre-hospital setting. So a bit of this scoop and run in our patients in pain actually seems to be a bit of a disservice to our patients. I want to point out too, this because they spend a bit of time in the discussion putting this to point. About a 50% chance of having your pain treated non-pharmacologically by an EMT, which I appreciated because it was higher than our ALS counterparts in terms of treating their pain. So even our paramedics who have more tools in their toolbox to treat pain, our EMTs still treated pain more often than our paramedics. So I thought that was worth noting.
As your friendly neighborhood EMT over here, I also appreciate that you noted that. And I do think that's an important call out. Table 4 is restricted to just the BLS clinicians. And I applaud the authors for taking this look, because often the focus is on urban settings where we're more likely to have an ALS clinician present. But what about the urban rural disparities in areas where we don't have access to an ALS clinician? What should we be doing? And this table gives us a lot of evidence that, hey, what we do at the BLS level is really important. All right, now we've made it through all of the tables and figures, and I'm going to open it up to general discussion. So audience, now's the time to get in your questions while we discuss a few closing thoughts in terms of what does all of this mean? What else do we need to study? And what should we do with this information if we're working at EMS agencies? And so I'll go ahead and start, and then I'll turn it over to Tony and Michael for their thoughts. For me, the key takeaways here are pain is undertreated, especially in children. And though it wasn't split out specifically in this study, I would wager a lot on that the younger the child, the less likely they are to receive pain management and probably pain assessment as well. So those are some important areas for us to focus on, not only at an initial EMS education setting, but in our continuing education as well. And something for us to target specifically with our robust quality management programs. Pain is by and large one of the top reasons that emergency medical services is called, or is a part of an encounter for the vast majority of encounters. So something that not only applies to children, this likely applies to adults as well, but gives us some good evidence that we should take this opportunity to look at our protocols, to not just consider whether or not we gave a pharmacologic intervention, but to think about our toolboxes too. What do we have available? Do we have non-IV routes available, particularly with children? Though there's plenty of adults who, after an injury, the last thing they need is another needle. And so for us to consider what's in our toolbox, and are we aligning ourselves with that 2021 evidence-based guideline?
Yeah, and I'll jump in. I think those are great points, and one of I think the most important things to take from this study is just it just adds to the continued literature that what we do pre-hospitally really does matter. Not only can, if we take appropriate measures, can we reduce pain at the patient on scene, but we can reduce the time to pain management and opioids and analgesia in hospital, and we can make sure that care is continued to be provided throughout the continuum of care. There's that. I think that is a huge take-home point from this paper, and it's something that we continue to see in literature, that as we get more and more outcomes and linked data, that EMS does have an important role to play in the continuum of care. We're not just taking patients to the emergency department, and this particularly, we're talking about children. We're talking about making them more comfortable when they've had empirically a very bad day, right? So I think that it's really important. Remy, you talked about this earlier about this can dictate how they interact with healthcare throughout the rest of their lives. And I think that was really insightful, and something that I just wanted to highlight again, because again, we can make an improvement on scene. We can make improvements throughout the continuum of care and potentially throughout the patient's life. So it's really important. And I really, I think this was a great study.
I couldn't agree more, Tony, and I think those are excellent points. This leads me to start thinking, okay, if I'm a EMS clinician or I'm a QI person, this would be a really easy report to run out of any one of the charting softwares. You could very easily do a search and filter for younger than 18 years of age and any documented pain scale, and then pull all the interventions that were performed. If I was in a QI role at an agency, I would pull this report and want to see, are we at 19% like the study noted in terms of analgesia for pediatric pain? Are we better than that? And then maybe we're doing great and that's worthy of celebration. My guess is we're going to find that most agencies are within this same metric, which tells me why. It makes me start asking the question, what are the barriers to administering pediatric medication? We've talked about some of the myths today that have been fairly well debunked, but I'm also thinking, looking at protocols to figure that out. If we've got a weight-based dosing structure, but our medication comes in 100 micrograms per ml in a case of fentanyl, is the difficulty here because we don't have a 1 cc syringe where we can actually draw up 0.3 milliequivalents or mLs of a medication. If that's very simple problem to fix. So I would start looking at my protocols to try and figure out, why are we missing the mark here? If we've debunked the myths on why we give pediatric pain medication, is there an actual barrier for our safe administration of this medication in terms of what's required of us in our protocols, our math skills? I mean, dosing charts are something we advocate every agency use. So do the math, have a chart saying this is the kilograms, this is the mLs of our specific medication that you administer, and then run the QI report after another 6 months and see if we're making an impact with some of those interventions. I think trying to figure out the barriers to success here is a big deal.
And I love that thought process, Michael. That is following the model for improvement. And so in improvement science, we talk a lot about looking for drivers, and those are those root causes of what's actually going on. And what's actually going on in one system might not be what's going on in another system. We're very quick to move to education or memos, but often that's not the only cause. And so thinking even further, like you just said, what equipment do I have available? What tools do I have in my toolbox? What do my protocols actually say? Is anybody being held accountable for these protocols? Those are all really important things that we can go home and do at the local level. And actually, it's an exciting time in EMS because the first time in our history, we have 11 evidence-based measures that we've agreed upon are a national standard, and that is the NEMSQA measures. And of course, we love a good acronym in EMS, but NEMSQA is the National EMS Quality Alliance. And so one of these measures is for patients with a pain score above 0, and you can modify this up as you like. If you want to start, in the severe category, that's fine, but they are looking at this holistically with patients who had any pain reported. Was there a pain reduction during the EMS encounter? And I think it's really important how they chose to look at that measure of, was there a pain reduction? Because this puts BLS clinicians back into the mix. It's not asking, did you give an analgesic medication or did you give a narcotic? It's asking, did you do something that relieved that patient's pain? So I think that's something for us to take home. Now, I do see an audience comment in here that I think is important. So Chris mentions that there's a trend towards creating separate pathways for chronic pain versus acute pain, and this encouragement to engage in shared decision-making or consult when there is a gray area. And might this be a way that we could improve pain management and get past implicit bias? I'd like to say that, I think these things are great ideas to have that consult, especially on chronic pain and what's not working. But in this study, we're talking about acute pain. And in a study that Tony and I both recently worked on in adults with confirmed long bone fractures, we saw that a large proportion of those patients who had severe pain and a confirmed long bone fracture on ED arrival didn't receive pain management. So it's probably not the only thing that we need to do. It's probably a good thing for us to consider, but for us to not put the blinders on and only suspect that we have implicit bias when it comes to chronic pain is going to be important, because even with objective, and I'm doing that, objective air quotes, injuries, we still see that there is bias in how pain medication is being administered or how pain is being treated. So something for all of us to probably build into our quality management programs, and not just to build it in. I encourage all of you to share what's working well. I teach in a lot of quality improvement courses, and I've seen a lot of agencies come up with innovative solutions on how we can better pain management. And so if you are one of those agencies who takes this on as a project, share those findings, whether it be through a research project or a journal publication, in one of the trade journals, or, find a way to share that finding with others so that we can replicate those things that are working well.
I think that's so important. And to that point, one of the limitations actually noted in the study was that they didn't have any of the agencies during this time period that utilized a non-opioid medication for enrollment. I have two thoughts. Sort of one pathway is the more tools in our toolbox to treat pain, the better off we are. That goes to Chris's point, where if we're treating a patient who's got chronic pain, I've got different tools to treat that pain. I think we have different tools to treat stable versus unstable tachycardia and unstable versus unstable bradycardia. Why wouldn't we for acute and chronic pain? But my other hurdle is we're not treating the pain. I mean, 19% got some sort of pharmacological intervention. So there's also a barrier here that I need to get over that says, I don't care what pain management you have, we have to get our providers administering it. We have to get them giving the pain management. So I don't know how we've discussed lots of reasons on how we do that today, but I think adding more tools to the toolbox is only good if we can get you to actually use those tools.
100%. And I think you've hit the nail on the head on one of the most important things is examining what's in our toolbox. What do we have available to us? And I now have a very unpopular task of getting us wrapped up as we are approaching the end of the hour, but I will allow for any final comments, and I'll start with you, Tony, before I close us out.
Yeah, I just want to again say this is a great study. Congratulations to the authors on getting this published. And I'm really interested to see this study replicated in the next 3 to 4 years, maybe sooner than that. And let's see if we can improve and provide pain management more equitably and at a higher rate.
Absolutely. And Michael.
I couldn't agree more. Hats off to the authors. This really is a landmark paper that's starting to look at this. It only supports what's already out there and gives all of us a call to action to make sure that we're properly treating our pediatric patients.
And I agree with that as well. I can't wait to see this study replicated. I highly suspect that this doesn't just apply to the pediatric population. What we do in the pre-hospital setting likely replicates for adults in terms of pain management and beyond. So I'd like to see also this study replicated in other settings with other treatment pathways, because I think that diagnostic momentum is a real thing and it's really important. So with that, I also want to iterate the kudos to the authors and the congratulations. This was no easy study to conduct. It took a lot of resources, a lot of people working together, and had some important results that are truly adding to our literature base. My final takeaway is that assessment really is king. So make sure that we are doing an assessment and a reassessment. I didn't see how many in this study didn't have a second pain score, but that is vital for us to measure something like the NEM score measure for pain reduction. We need at least 2 pain scores, even on patients who are too young to talk or too young to point at faces. So considering those observational pain scales, Flack and Chaps. And with that, I'm going to go ahead and do our last logistics on announcements. So for those of you who wish to tune into our educational podcast, this is really exciting. We're going to have a special edition of the Education Research Journal Club podcast coming to you live from the International Scientific Symposium at EMS World Expo in New Orleans. That will be on Friday, September 22nd at noon Central. And then we will be back here with the clinical podcast, as always, second Monday of the month, which will be October 9th. And with that, I want to thank you all for listening and look forward to nerding out with you all next time.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.